Well, I'm Anne, and I manage a day centre for older people or people with problems associated with old age, and the Willows Day Centre. And what happened is that one day we have a morning meeting, and it just so happened that one day I happened to just say, "Do you know how loud this place can be?" And other staff said, "Well, do you know I went home with a headache yesterday and last Tuesday?" And I started to take a little bit more notice of when people were noisy. And I actually thought, oh, I know it'll probably be, we have some people that are louder than others, and some staff, it's all down to staff probably, or things they control. So, but when we started to think about it, I was then getting told, well, do you know that one of the service users has complained that it's a bit noisy? And I started to take a lot more notice. And that's why I did this project, Safer Every Day. Now, we provide therapeutic activities and personal care for people, mainly with dementia. Not everybody, but the great majority have dementia. But they might have physical problems. They might have as well. Most have physical problems of some kind, or sometimes people have the physical problems without any mental health problems. We're staffed by mainly nurses, but there's a lovely occupational therapist, an occupational therapy assistant, and then nursing assistants, really lovely. We provide a multidisciplinary approach to care. And it was also proved with this, that the multidisciplinary input was really good. So how did we know the centre was too noisy? Service users complained, more than one. Service users' level of agitation were noticeably more intense and more frequent, and this was especially with one person. Staff reported going home with headaches due to noise levels in the centre. Can I have that on now?
The 17th century. Dodo, yeah. Next one is, he is known in the company as the Jackal and
Actually, you're nearly...
Now that is the tea trolley. That is just the tea trolley. To start with, there was a little bit of somebody speaking, and that was a group was running, and I did tape it on my phone. What I'd like you to do, could you just talk to each other now? Just tell each other what your name is and what you're going to be doing this weekend. And can we have this again?
Hello, my name's Ryan. This weekend.
Speak up a little.
Thank you. Now I did that to actually just show how disruptive that noise in particular turned out to be. I didn't actually think of equipment being a problem really until we started to talk about it. But if you have cognitive problems, which I have said the majority of the people who attend the Willows have, it must be terrible. It's terrible for all of us. It's terrible for me to listen to for a few times. So you can't have a conversation or even follow what people are saying. We had a meeting and we investigated, and people started to say, well, actually lunchtime is very noisy, and certain groups are noisy, like certain service users are louder than others, and certain staff are louder than others. And our aim was to reduce the noise sort of overall. But while staff were preparing lunch, during lunch, and then clearing up afterwards, it turned out that lunch, the whole process of lunch was really noisy. But also to reduce the level of anxiety for the service users during lunch. But as I say, one in particular became very vocal if things got too noisy, and also to improve the overall experience of lunchtime period for the service users. So what did we do? We had a meeting. Now it sounds like it was only one meeting, but we meet every morning at the start of the day. And so this was a topic that came up a few times, but we had one particular meeting where we only spoke about noise. And it was agreed that staff, service users and equipment contributed to the noise levels. And what was the worst noise? Setting the tables, then during lunch, and this is specifically, it wasn't just lunch itself and the service users chatting during lunch, it was also staff not having specific jobs to do, so they were hanging about, chatting. Or they were talking to service users maybe, but loudly. And then clearing up after lunch, because we don't have any housekeeping staff, so we have to do that ourselves. And some service users are chattier than others, as you'll find. And the tea trolley. It only became evident when I actually looked into it and when the team started to get involved, just how awful the tea trolley was. And that was all that clip was mainly the tea trolley being wheeled in, 10 yards, and it was bad. Now, the plan after we had settled down and we decided what our aim was, and our aim was, in the end, it wasn't just to reduce noise, it was to reduce the level of anxiety and improve the overall experience of service users during lunch. Now, to start with, that's not what I immediately thought of. It came out by investigating. And we had our measures, and our measures, the service users' behaviour and responses to environmental noise, but also the complaints, not only our own complaints, but the complaints from service users. And a secondary driver was how staff engaged with the whole process. Because as with everything, there's some staff who are more open to any new ideas or any changes. Now, I've left copies of the driver template over there. But we came up with the service users, the way staff are noisy and contribute to the noise. But with this came our philosophy of care, and our philosophy of care is to provide a service for everybody that enriches their lives, and where it's as Vicky said, because we're not really a medical unit, we're there as socially, so that people could go home and being better off for being with us. And lunch featured, as I expected, quite heavily in this. But one was also the sliding doors. We have a big room that can be closed off, but there's a big door, concertina type door, and I had really never noticed just how noisy it was, being opened or closed. And then the equipment, and you've heard how noisy just the trolley was. And the action plan. We planned what we were going to do. This was really good. We decided what we were going to do about it, and I'll go on further. And then we studied the outcomes and decided, whether what's happened was what we expected to happen or not. And then we acted. And the plan was to change the procedure for lunch, and this was to do everything more quietly, and this is to clear away plates when everybody had finished lunch. Now, we had also decided, almost as an addition, is that we wanted lunch to be not only an activity. We'd already thought it was an activity. We'd viewed it as an activity, but we thought we wanted it to be a process where people were enriched. So we thought we'd start running it as if it was a cafe, as if people were in a cafe, so where this is where the plates are cleared up when everybody's finished. And where possible we do that. Sometimes we can't, due to anxieties, we sometimes can't. People fretting over not having pudding, we like to do that. And it's rinsing the dishes. As I say, we don't have housekeeping support, so we have to do all of that. Closing the sliding doors to reduce the noise. Staff who are not allocated duties over lunch period. Now, to engage with service users, and we decided, because there's lots of little jobs to do, there's the person dishing up the food, the person doing the waitressing, somebody cutting up because there's always food to cut up, and somebody preparing the food for special. It's like the, they call it, not the dipsy, the special diet where people have to have a certain amount of moisture. One person does that. Staff, and only then, if everybody has got their jobs, and if there's enough staff, then the staff go and actually join a table, sit down, and make it more sociable. We're going to try Dyson sheets under mugs on the trolley, because a lot of them rattled. That was a lot of the noise of the cups the mugs. And we decided to contact estates to tighten the trolley wheels to see whether this made a difference. What happens now is that the biggest change was that staff have become quieter, they just have. Staff push the trolley slowly, and there's almost a competition now who can do it quietly. We also use heavy books on the bottom to reduce the noise, and it does. Somebody just said, I wonder what would happen if we put something heavy on the bottom, and it worked. Staff wash up quietly, and we're not closing the dividing door, but that's because at the moment we've had quite a lot of staff sickness and people on leave, and we haven't had enough staff to close the door. We've needed to have staff in the main room. But what I can say is that we also decided that lunch is actually quite noisy. It's not as noisy as it has been, but it is. We want to run it like a cafe, and cafes do get a bit noisy, don't they? And we wanted to make it a more pleasurable experience for everybody. But we haven't had any complaints since this started. Okay, and this now, could I have that one up? Can you hear? Somebody said at the end, I can do it quieter than that. It was never meant to be a competition. And there's a big difference, I think. Even though it's the same phone I was using, and I was standing in the same part of the room, and I think there is quite a big difference. Just one thing I wanted to add is that not everything worked. We had, just talking about the trolley, I said we put Dyson sheets under the mugs, and that was the one thing that actually was worse. They just seemed to rattle to each other. So that was the one thing of the ideas we had.
My suggestion as well.
But we wouldn't have known. We wouldn't have known. You don't know. So that was the one thing that didn't work. But the trolley, tightening the wheels worked, pushing the trolley slowly, and that's actually the biggest change. Putting the weight at the bottom of the trolley. Staff just being noisier, being less noisy. Also, we also though, and I think this is also an offshoot of that, is the people who start to respond to noise, we recognise earlier and we respond quicker. So if we need to distract or move people away or maybe quieten people down for a bit, we do that much quicker. And we haven't had any big or major outbursts for quite a while. Yes, quite a while. Certainly no, I don't think any incident forms for a long time. Yeah. And we've decided that if we ever needed to buy another trolley, we would buy one with a quiet one. We'd actually ask to have a trolley that is quiet, because none of us, I certainly didn't realise that the big problem was in this wonderful trolley. And we all have trolleys, don't we?
Yeah. Well, we have one that does our sort of delivery of our cups and coffee every day, and there's two that can use, the very noisy one and the nice one with nice quiet rubber wheels. I prefer the one with the rubber wheels, but
Yeah.
there's a big difference. Who's ever worked in an organisation, presumably not many then, in an organisation that has adopted shared governance? So you've heard of it but not worked in it. Would that be fair?
In terms of
Did the organisation in which you work have a shared governance
throughout the whole
leadership? Yeah,
Yeah.
it did. Okay. Do you want to come and do this? Come and join. Right. Anyway, I won't put you on the spot. That's good. Anyway, what I'm going to do is just briefly introduce to you what shared governance is about, and for you to ponder on, because this is what I think we need to do. In a very quick nutshell, I could probably just do the one slide really, but I'm not going to. I'm just going to qualify this with it. It refers very much as a nursing concept, okay? So where it says nurses, it doesn't mean just nurses, to be fair. It applies to absolutely everyone. And one example I had, it referred to people who worked in the IT team who were not even based in a hospital, you know, they were remote somewhere in wherever they were. But so just ignore the term nurse as it being the nurse. It just basically means anybody who's delivering any healthcare. So please, those are colleagues who are very passionate about what they do, and it's not being a nurse, don't feel put out by this, because it is literally, whilst it is a nursing concept, the concept runs for every sort of discipline who works within healthcare. And basically, in its simplest form, it's a decision-making process that puts the shop floor at being the people who make the decisions. Now, who in the room has ever had an idea, being somebody on the shop floor, who's then had it quashed by leadership? Come on, really? Only 3 of you, 4 of you? Come on. Yeah. So what we're looking for is a real partnership, a real equity of how we work, and a real noticeable accountability. Now, a lot of us are accountable practitioners by the very fact that we do what we do and we have a professional accountability. But actually sometimes, I don't know about you, but sometimes we might feel we don't ever get the chance to be fully accountable because the decisions are made for us about certain things, which make it very difficult for us to be accountable to things. And that can also cause us problems. So it's all about accountability, and again, it's then about ownership, and it's ownership at the right level. Now, this fits very much with Safer Every Day. For those of you who can remember about Safer Every Day, when I started to present it, I talked about the principle, this, being very much based in a flat hierarchy. Yeah? So there, it doesn't matter, I've said it right at the very start, so it doesn't matter what role you take, I don't care what role you do, politely, who you are in this organisation, you need to feel able to raise a concern to whoever, be it the Chief Secretary, be it Professor Beale, be it Steve Winterflood, your manager or otherwise, doesn't matter who they are, should be able to go up to somebody and raise a concern. Now, I don't believe we're there yet, I think we're improving, but we're not there. Now, shared governance is all about that, breaking down a hierarchy and making it more of a level playing field, so it doesn't matter who you are. Anybody can say anything, everybody's point is valued, everybody's point is possibly the solution, and we work towards a more shared ownership and leadership, basically. So, all fits well. It basically makes people feel that they're part of the management structure. None of us like to be told what to do, very much. Occasionally we might, but not very often. We prefer to be engaged in processes, don't we? Engaged in decision making, engaged in what's going to affect us and how we deliver the care we deliver, in whatever way that is. What people have found in places that have adopted shared governance is this is the reality, is you have people who are remaining in employment. Now, some of us have been in HSC and in healthcare in general for a long, long time, but that's probably because you kind of want to be a nurse or you want to be an OT and you keep doing it. But you may well have years of frustration about how the organisation has gone about things and how you've perhaps not felt supported and how you felt not unheard and you think things have gone the wrong way for patient safety over that time. But this provides us with people who remain in the job because of doing shared governance, that people are more satisfied and happier because of what they're doing. And actually, ultimately, the one that we should all worry about and care about mostly is better safety and healthcare for all, and that includes us, not just the people we support. You get less service user complaints because not only are we engaged as shop floor workers, they are very much part of the process. So if you have shared governance, that means actually you get users who are part of your committees, who are part of your leadership, who become the decision makers about what goes on. And actually they've found that it results in shorter length of stay, which is also a positive and will obviously result in massive cuts and better use of time and better use of resources. We'll get people seen quicker, people out the door quicker, all of those things. So there's lots and lots of benefits. As I say, I'm trying to go relatively quickly through this, so bear with me. We have other things we can do on shared governance. I didn't bring it with me, but we have a board game which I'll talk about in a minute. When you look at this is a bit of a contrast of how potentially we can talk about what we do ourselves as individuals, how we self-govern ourselves, what we do, what our goals might be. We talk about what I would describe really as the management style that we tend to see mostly. We get asked by people, and some of those managers may well take the time to use what they've asked of you, you know, to think and consider your ideas and take those forward and use them and implement them. But actually there's no real sign up. They don't have to do that. It's just whether it floats their boat as well. So I'd say we sit potentially in the middle column at this present time. And what we want is a shift here into the shared governance where basically for like the goals there, so instead of leaders requesting our input, but then they can do what they like with it, they can take it or leave it, we're all responsible and have the authority to make those decisions and are accountable for those decisions that we make. How many times do we say it's them, right? You know, they've made that decision. I don't feel very much part of it. It isn't very often a we. Maybe the manager says the we. Well, we did this, but the person on the shop floor probably feels, well, I didn't really have much say in that matter. So we changed that to become, basically they're interreliant, they're dependent on each other in order that it works. So you have both the staff on the shop floor versus the leaders of your organisation, your managers of your organisation, coming together and leading in the jointly, if you like, together on all decisions. Things that there, the bottom, that are, sorry, I'm catching the light. Leaders, so how decisions are made by work team with no external input or guidance. So that's kind of where we might be doing our own little thing. The final decision, the buck stops with the people above us. Is that what we feel at the minute? People make those decisions above. I think would be reasonable and fair to say on the whole that's what happens. But what we want, again, is then we want clear leadership that articulates the decisions that they're making, that demonstrates an embrace of your ideas, our ideas, shop floor ideas. And we shift then away from the idea of having either no leader, so I'm basically doing it all on my own, I can make my own decisions and they may be good, they may be bad, away from the leader who dictates and gives us what for and what we're going to do, to a joint shared kind of leadership where we're making those decisions together. And it results in a much more, it's probably very straightforward, and I think it is very straightforward, it's just we don't necessarily do it. It works in a much more collaborative way. We become more collaborative together as we make decisions that affect the patient, the service user, but require each and every discipline in the room and those that aren't even here to influence that decision. Now, the example I had was that somebody shared was it was a very touching example. It's one of those ones that pulls at your heartstrings, and I'm not going into detail of it too much, but there was a woman who was had received a really poor prognosis and actually was due to see her son or daughter get married, and the reality that was not going to happen. She was not going to be leaving that hospital bed, and it was the weekend. Now they came together as a team, as a governance team, as a shared governance approach, and they thought about all the ways and means that they could make what is going to be that person's very last living memories potentially as good as possible in such very difficult circumstances for all concerned. And they had arranged for it to be sort of like video Skyped in, so she's there but she's not there. She's in the room and she's involved in that process. That was the plan. And of course, as we well know, they don't always go as easy as we might think they will, particularly when it comes to IT. And that's not to have a dig at our IT teams, but we know the difficulties and strife that can be. So they had a problem where the room didn't have a TV in either that was working, it wasn't connected to anything. Yeah, you can have it, but it's not until about 5 weeks' time. And all these kind of challenges. We can't do this, we haven't got the right connection for something else, and it really isn't possible. All these things came up, and basically what happened was the coordinator of this lady's package of care asked the IT guys to come up and see the environment. Perhaps a little bit cruel, I suppose, in some ways, but it made it real. And if anybody was at the conference in December, our nursing conference, November, I should say, Tom Carhill spoke about that very much. It's about making it real. And he never discusses cases about people without using their name. So I'm not obviously using this person's name, I have no idea who it was, but if he was discussing this case, he would make it very personal and tell you that it was Vicky. And I think this person was trying to do the same thing. So they basically became aware of who it was they were trying to provide this support to, and they were saying, no, they can't do it. It wasn't possible for at least another 5-6 weeks. This person didn't have 5 or 6 weeks, the wedding's on Saturday, etc., etc. And it wasn't left last minute, this person had just come into care. These two very young IT guys turned up, very young, and they too could not see why we couldn't do this. Why can't we do this? This is just ridiculous. So they went away, and I don't know what they did, but whatever they did, they went away gung-ho, and they managed to get everything set up within that space of time. They managed to get the TV in, the cabling, whatever it was, and they all turned up for the wedding as well, with their suits on and a little, corsage, whatever they call it. They all turned up to be present while that wedding took place, and actually one of them had spoken with the son, the daughter, whoever it was, and actually physically gave the mum, who was the patient, her bouquet or whatever it was that she was going to have, physically had handed it to her. There wasn't a dry eye in the house, but that was just talking about how you can actually, if you all come together and work together for what we deem to be what we're here for, our patients, our service users and their family, we can make those differences. And nobody stopped them. There wasn't anything, well, we can't do that. No, you've got to get permission from this person, that person. No, they all came together, they worked together, and it pulled it off. Now that's a lovely, nice, very emotional, but it's a really nice story. But there's lots more day-to-day, run-of-the-mill examples of where shared governance works. And I'm sure if we adopted it, we would find the difference in our own day-to-day work. These are just some examples of where if you use it, this is what we'll get. If we don't use it, we'll stay in this kind of column on the left. What we have found at the bottom here is that nurse satisfaction, whoever you are, satisfaction improves, the turnover decreases. We have got such an issue with staff turnover, and the quality of care, which is the bit that we all want to do well, and not just well, but very well, it improves. So it's kind of, for me, a bit of a no-brainer. Those things that become impossible, a bit like the principle of safer every day, when I've turned around to you and said that actually those things that you thought you couldn't do because either you're told you can't do, then come to me, and through Safer Every Day we can do it, because that is the principle of Safer Every Day, the principle of shared governance. You can make changes, and they're made, if you like, they've just said decisions are made by people who are actually doing the job, rather than people who have become either so far removed or have never been in those positions and don't really have a true understanding of what it is like to do what we do. And I think we all want that. So what can we do? We can do a little bit about reading about a bit more about it. We've also got some puzzles, board games called Shared Governance. I've got 4 copies of it, which you are free to borrow and use amongst your teams, but I do want you to use them if you borrow it. I don't want it just to sit on a shelf. And it's literally just a board game that just gets a bit of discussion about what they'll ask you questions, and the other. So one team will ask a question, the other team have to come up with sort of a response, and then the team who asks the question decide whether it fits what the answer is on the page. Some of them are around shared governance, some of them are just general governance and patient safety processes, and some of them will be so difficult that I probably don't know the answers either, and I'd have to go away and think about it. But that's the whole point. It challenges us to sort of develop our understanding of governance and what it really means to be an organisation that is focused solely on patient safety as being the focus. So we can do that. That's something we can do. We can commit to taking that approach to being even if we just do it individually at this present moment in time, that we collaborate and work with people to get their ideas and consider all ideas to make things move forward. It's definitely something that we as a quality and safety team are keen to push forward, and we have support from other people, who currently have the say-so, that they also believe this is the way forward. We can start to deliver as well. So there's certain aspects of what you do is in your day-to-day work that can demonstrate your approach to shared governance by delivering your care and support in such a way, involving your team so that they don't feel that they're not heard and not their opinion isn't worth being voiced. And we can encourage across our organisation that this is the way we need to go forward. So I don't expect you to remember half of that. I've kept it extremely brief. But it's something that we are starting to move forward with. Okay, so it will be bounded about a bit more, hopefully. We'll do a little bit more about it at some other sessions, or do some more training, or come and talk to your teams about it, whichever way works for people. But this is something that as an organisation, if we really want to change the culture within our organisation and ensure that we are delivering safer care, then this is really another step towards it. And it fits fully with the framework. I'll just very briefly give you some. This is quoted, okay, so I'm going to use this because otherwise I'll never remember it. This is Anne NHS area. I'm not going to tell you where it is. But they started their journey in 2012 as a response, so it makes me think we should be doing this, as a response to low staff engagement and morale, poor retention, and a looming national nursing crisis. I think we've got most of those, have we not? And over the past 6 years, the staff have surprised us time and time again with their ideas, their passion, their dedication to their patients, the trust, and the NHS as a whole. Now, I don't know that I'd be surprised, because I think actually most of us are there with ideas. We're passionate, we're there for the service, we're dedicated to our patients. We might feel a bit run down at times, and we are dedicated to our organisation. We wouldn't be here if we weren't. Our journey began with the creation of shared governance, a model of leadership which encourages personal and professional development while focusing on improving patient safety, patient experience and staff experience. And it follows those 4 key values: accountability, equity, partnership and ownership. So they went on to say they developed these staff councils, which is I don't know if I left the slide in. I might have taken it out. Yeah, I did take it out. There's a structure of how you do it. There's councils and there's committees, and then there's a task force group when you need to do something. So they created all these little groups, and these little groups had people from all over the organisation. So be it the support staff, people delivering the care, management, you name it, was on it. Some representation, and most importantly, service user and how we engage with them and their family. So they were representative on these committees and councils. And a council member said here in 2018, so it's a real up-to-date one, I didn't know what empowerment meant until now. So by doing this, they felt empowered to make the changes, to do what they wanted, to deliver the care that they wanted. So I think it isn't new, it's been around since about 1976, the idea. But it's new to a lot of people about getting rid of this hierarchical management and leadership style that we seem to have adopted for so long. And it takes time, because it takes time to have an autocratic decision making rather than a hierarchical, you are going to do this, we're going to do what I tell you to do. Teams will begin to work more collaboratively, and I think that's something that we all refer to silo working, and we don't necessarily collaborate as well as we could. This could well help us along that journey if we take this approach. So I would just leave it at that. If you have any questions for me, I'd say let's arrange to do that out of here so that we can set some time to actually really talk about how we could do something in your areas. Not because I don't want to answer the questions, but because I want to move on to the next bit of really good work that's been going on. But as I say, I'm just introducing it here, if that's okay.
Yeah. So can I ask you all just to stand up if you feel able? Because you've all been sitting down, haven't you, for probably a couple of hours. Do you want to have a little stretch? A little stretch? Only if you feel comfortable to. Because you've all been cognitively engaged. You've all been thinking. So nice one, Steve. A pumping action going on there. Okay, you can sit down now. That was just to give you an opportunity to get physical for a second, because part of what we're talking about here is it's kind of interesting because it talks about the difference between sort of mental health and physical health, like they are different. You know, the mental health and physical health, it's all part of the same thing, really, isn't it? You know, if you look after your mental health, and you look after your physical health, and vice versa. So I would actually like to call forward Trish and Susanna. Give them a small round of applause, please, because they're part of bringing this forward. If you'd like to take a seat there, come on down. So questions at the end. I'm going to basically share this with Susanna and Trish, who volunteered me to speak to you about this. She's very, very kind of them. So there's this sort of, it's interesting, this idea about mental and physical health being separate. We know they're not separate. We know they're intuitively linked. And there's lots of studies, as Vicky said earlier. Nikki Thomas, our colleague in the R&R team, spoke to this group last year about health inadequacies for people with mental health problems. So I had a quick scan around this. Why did we choose to do something about using the Rethink document? So we know from the BMA, they did a study looking about mental health problems. We know the largest source of burden of disease in the UK. Lots of unmet need, basically. If there's any common presentation that all the mental health issues will have, it's a difficulty in communicating. It's a difficulty in accessing services in some ways, whether that's GP services or just getting a basic health check. We know that people with mental health problems, they can have higher levels of heart disease. They're less likely to participate in physical exercise. They're more likely to smoke. Is this unusual to people? Are people aware of some of these stats? Yes? Yeah. Okay, good. And so we knew it's something that we needed to address. I could talk to you for hours about audit. Anyone want to know about audit? Yeah? Can I see a show of hands of the people that know about the SCAPE audit? Oh, isn't that good? Lots of people know about the SCAPE audit. So SCAPE audit's going across the whole service. What do you mean, no? Okay, all right, good. So we had a SCAPE audit in our department, and one of the questions, so some of the standards that sort of came up that indicated was standard for safeguarding service users. It kind of looked at inpatient admission and in the community assessment of physical health. Care is renewed and recorded during assessment. That was one of the standards. We weren't always doing that. Obviously on the generic sort of risk assessment and generic assessment that we have, it asks those questions, but we weren't always asking those questions because we work in mental health. We've got a certain amount of time to ask somebody about what's going on, so we tend to focus on the presentation that we're being asked to address. So it's not necessarily about physical health, but that's a standard. Standard 5 also about accessing of referrals. That was sort of talking about people having access to physical health checks as well. Standard 6 was saying that it was important to look at lifestyle factors. So exercise, smoking, all those kind of things as well. So we realised that we needed to address it there. Standard 11 as well, it propped up in Standard 11. Service users have access to intervention that promote self-management. So that's about preventative healthcare checks and things like that. Also refer service users to other health providers. So that's another standard. That might be about people like Health Promotion or Quitline or people like that. So we realised from the SCAPE audit that we wanted to do something about it, and our two very talented nurses, Susanna and Trish, volunteered, because we have a shared governance type approach, volunteered in the team meeting to look at the documents that are out there, that we can sit down with people and ask these questions about their physical health. We didn't want it to be onerous or heavy. We had to kind of weigh it up, didn't we? But you took the ball, you ran with it, and you looked at the different documents that were kind of out there. And we found the Rethink document was kind of the most useful. So why Rethink? Well, physical health monitoring is an integral part of caring for service users. Factors that contribute to premature morbidity in people experiencing mental health problems include poor diet, lack of exercise, smoking. That looks like Marlboro to me. I'm no expert. Alcohol consumption, no idea why it's got a red cross on it, like it's dangerous or something. Drug use, including regular use and effective psychotropic medications. That's actually quite a big one as well, really. It's and in the study you'll see some of the results. It asked about medication, and we got some interesting results. What is Rethink? Well, it was designed by these people here, and it's obviously recommended by NICE, the National Institute for Clinical Excellence. So we knew it was a good thing to do, and we knew that lots of research had been done into this particular tool. So we did a pilot study. We took a core group of service users with recurrent or server and enduring mental... Server? What? What? There's a typo. I spotted it. It was my problem. I'm afraid somebody stole from my office my Microsoft Office suite. Okay, and if there's anyone here, I will find you, because you have my word. You have my word. Tough audience.
You excelled in that.
Thank you, I excelled in that. Very good. Oh, excellent. So we know we have kind of two streams of service users within the Recovery and Wellbeing Service. We have the acute presentation people who may be coming from the inpatient ward, either Tortenay or Crevachon, and all people who are acutely unwell within the community, and they come to us sort of like an 8-week program of activities, wellness-based kind of interventions. But we also recognise that there are people with very much an enduring presentation who benefit from from just dropping into some of our groups, whether it's community-based groups or within the Oberlands, and that keeps them well, that keeps them out of the ward. So we've got these two groups. The first group, the acute group, is a very high turnover group, so they might come to us for 8 weeks and then they're gone, they're back to their lives. But the enduring people, we've kind of got a good core segment of people that we can look at. So we chose that group. We didn't make them do it, we offered it to them. We sort of offered it to them, and the sort of age range was between 20 and 70 years. There's quite a good age range of people there. That's not the staff, that's the service users. Under the care, some of them being under the care of mental health services for up to 20 years, a long time. There were males and females, and 19 in total were identified. So that's kind of how the ages were sort of broken down. It's kind of a fairly even spread there between the sort of 65 plus years, round about sort of under 25 or 56 to 65, and then 46. So sort of the older range, I suppose, of people. That's how many people sort of accepted and declined, and I don't know, what's the DNA bit? Just didn't show up?
Yeah.
Yeah, okay. So the results and findings of physical health conditions. So that's quite an interesting pie, isn't it? So we've got bladder issues, diverticulitis, sorry, I've got speech problems, ulcers, aches and pains, hepatitis, nerve damage, asthma, heart disease, spasms, recent feature fractures, diabetes and arthritis. So really quite a big spread there. Diabetes is big in there, isn't it? Very popular diabetes, obviously. You know, everyone wants a bit of diabetes, it seems.
What's the 16%?
16%. I think it was ulcers. No, aches and pains. Sorry, aches and pains. So it's quite generic, really. Sort of asking some of these questions, and we'll come on to that later because we're going to do it again at the end of this month or halfway through this month. Next week, there you go. God, time flies. So the results and findings regarding medications, prescribed medications. Some people have between 1 and 4, 6 people. 20 plus medications taken. That's incredible. Imagine what kind of impact that would have on somebody's physical health. 33% of service users stated that they did not understand their medications, they just took them because I'm told to. So that's kind of worrying, isn't it, really? So maybe some work there to do about psychoeducation. A third of the people accepted the referral from one-to-one appointments with a mental health trainer. So we're very fortunate in as far as Trish has built links with health promotion, and we have a health trainer comes to us every Tuesday, and it's a free service for service users to go talk about diet, exercise, general well-being, those kind of things, which is really nice and a very useful thing. 2/3 of service users engaged in regular exercise and walking. 2 service users were attending Quitline. 5 agreed to new referrals to Quitline. So that kind of comes back to that standard that I mentioned earlier, standard 11, about contacting other services. Often we find just by asking questions of people, it gets them thinking and makes a connection for people. They think, oh yeah, I could do that. We also have Quitline within the department as well, something else that Trisha's done. Good grief, you work hard. So we have Quitline clinics, both for service users and staff. Anyone can drop in on a Wednesday up until 6 o'clock. Trish stays. Comes in at 6 in the morning, leaves at 6 at night. Lifestyle, so that's an interesting one, isn't it? Including diet, exercise, smoking and drinking. This is where we made new referrals in the blue, and those people that were already in a service in the orange, either health trainer, Quitline, or we actually had to make an urgent GP letter. Do you want to say a little bit about that? Why did we make an urgent GP letter?
Well, one of the patients came in and said they were feeling quite giddy and unsteady, trouble like if they stood up and things like that. So we took their blood pressure, and I suspected they have postural hypertension. they went to the GP and that was all diagnosed. We had a few bladder issues as well, a bit of incontinence in some men, so we just wrote urgently to the GP. Heard back within the week and they were seen within a few days at the GP.
Good, eh? So good that we were able to do that, because actually I think, especially in Guernsey, where people sort of have a sense of having to pay to go to see the GP, even if they are in receipt of benefits or things like that, it's still a bit of a perceived barrier for some people. So they're less likely to go to their GP, I think. But if it's in-house, if we're just asking these questions, we can make those referrals very, very quickly. So we're picking up on stuff really, really fast.
And they were things that they hadn't told the GP previously.
Ah.
So, mostly because they're embarrassed, but yeah.
Okay, but not embarrassed to tell us, which is nice, because they're used to discussing their mental health problems. So we're kind of in a good position. Another interesting pie. These are the symptoms reported on a body map. So we presented them with a little picture of a human being, and they put arrows and described nerve pain, increased thirst, problems with urination, breathlessness, weight gain, weight loss, blackouts, constipation, chest pain, difficulty sleeping, headaches, pain, giddy lightheadedness, not lightheartedness, hand weakness, old surgery, recent accident, incontinence, heartburn and spasms. So again, it's about having a conversation with someone. I know these aren't all diagnoses, but they are concerns, health concerns that people have. So we talked about general health checks. When do people go to see their GPs? When do they have general health checks? Just going through that a bit. So the sort of the darker blue is within the month. The yellow is sort of every year. The orange is kind of every 5 years. So really a mixed picture about how often people are going to get sort of regular healthcare checks. But obviously now we've introduced Rethink, it'll be every year or maybe twice a year. We asked about preventative checks, cervical smear tests and testicular self-checks. And that's because, as we all know, if we can put effort and finance into preventative care, we're going to save us a whole load of problems later on. So we were asking about how often people checked themselves, did they know about it? Interestingly, more men said that no, they didn't. No, I thought they did. Okay, all right. It's about, I had to weigh that up about testicular checks. So that was good, and you kind of had some information there about checking, which was interesting.
We gave some leaflets.
Yeah, we had to review what kind of leaflets we thought that people might want to see. There were some very graphic pictures, which was
Some graphic answers as well.
really, yeah. You kind of enjoyed asking that question, didn't you?
enjoy asking.
Yeah. We didn't ask for a practical. We didn't have to
Demonstration.
No demonstration needed. No, that's right. I'm glad I wasn't called on for that. Yeah, do this, but not that. So bowel cancer screening, really important, very, very serious. So NA, can you tell me a bit about that?
So not reaching the right age where they
Okay, yeah,
invited to have one.
okay. But 20%? No, so maybe that's something that we kind of need to have more conversations with people about. So we looked at blood pressure. That was one of the standard tests that we sort of did, and quite a few people out of the normal range, as we can see. So again, as Susanna said, we had to make an urgent referral to GP in one particular case. So we did weight in kilograms, we did weight sort of averages. What will be interesting is seeing when we revisit this, if that's been influenced at all, because we have made referrals to the health trainer, we've given them information on Walk for Health and things like this. So it'd be interesting to see if those fluctuate at all. What did we do after the appointments? We posted an appointment letter, referrals made, action plans, physical observations. We decided as a team would we gather this information, keep it to ourselves and lock it away in a cupboard? Or would we gather this information and just send it to the GP or to the medic? Or would we gather this information and give it to the service user with an invitation for us to share it? So we chose the third one, because shared governance. We thought we'd involve the service user in those kind of ideas, and generally most people were pretty good about us actually writing to the GP as well. So covering all ground there. Together we created a plan of support, referrals and any other actions were agreed with the service user with a follow-up within 6 months or sooner. So we are following up within 6 months. Changes for the future. So we're going to look at calculating the BMI and waist measurements for service users. So we took weight, but that doesn't always give you an accurate kind of description. And when we look at some of the nice guidelines about psychotropic medication and sort of weight gain, some of the neuroleptic drugs for psychosis, we know that there could be weight gain. So we know that waist measurements is actually a really important thing. So with Porter tape measure, we'll be doing sort of round the belly sort of measurements and the inside leg and all that kind of stuff. So we're just going to be drilling down a little bit more next time. We're going to be looking for comparisons for physical health observations, like I said about the weight, so we'll be looking how it compares to for this one. We'll complete a News 2 for physical observations. Everyone know what News 2 is? Yeah, cool. We'll offer the My Health Journey group. So that is one of the groups that we run at the Recovery and Wellbeing Service. It's co-facilitated with the health trainer, and it's about sleep hygiene, diet, exercise, those kind of things. We'll offer closer links with health promotion, and we'll offer severed hands on sticks, which is a really odd thing to offer. Any questions at all?